Does anybody have any experiences that you want to share right off the bat of when you've experienced a contradiction of good healthcare not feeling good, or of thinking you said something but somebody hearing something else? Does anybody have any experiences they want to open up to the group with? All right, well, while you're thinking about it, I'm going to share one. And if while I'm sharing, you guys would listen for those words that maybe got a little bit misunderstood, that would be great. And I was actually, the week that Dr. Dickey came out with Vivian to train us as facilitators, we had a new family contact us as a home-based pediatric palliative care group to resolve some misunderstandings that had happened in the oncology department at our local children's hospital. And this misunderstanding had kind of led to them not doing maintenance chemo and that sort of stuff. As the family was going through the surgery to remove the brain tumor, they were told that we got all the tumor, yay. As they did the lumbar puncture, they were told that the lumbar puncture is clean, which the family took to mean free of cancer cells. And then when they were asked to come and do more chemo, they were really confused because they thought you got all the tumor, the lumbar puncture was clean. And so why would we need to do chemo? And sadly, they did not do the maintenance chemotherapy, and we got involved to kind of bridge that gap and change that decision for them, which didn't happen and would have been nice. Can anybody identify things that were said that were maybe qualitative words that meant something different to the practitioners than it did to the family or to the patient?
A lumbar puncture being clear, what does that mean?
Yeah. And how's a different way to say that? How's a clean way to say that, so to speak?
There were no cancer cells found in the lumbar puncture analysis.
Yeah. Any other thoughts?
I would add, it might be that it was a good tap that didn't have red blood cells. There could have been cancer cells all over there, but if they were just saying that the procedure went well and they got what they needed, that completely doesn't let the family know that there could very well be cancer cells.
Right. And how we think, and especially in jargon, one thing means something to us. And as the family shared to us, boy, we didn't know anything about cancer. We've never had it in our family. We're stepping into a totally unfamiliar world. And yet I don't know that the practitioners realized the level that they were starting at and the misunderstandings that were happening. What are some other thoughts about how things were said or taken or could have been said? Anybody have any examples that you want to share in your practice, or something that you've seen or you've experienced that's led to miscommunication?
One that's really common in the ICU setting is that the families are just told the patient's stable, but it's like all a relative thing. The patient's on ECMO, they're very seriously ill, but they're being told that they're stable.
Awesome. Exactly. That's a really great example. Any others?
I have an example also that sometimes we hear families that who are, the term I'm going to, the sentence I usually hear is, they're not a transplant candidate at this time. And at this time is this abyss. And so when families think that there are certain criteria that they will meet, then they will be a transplant candidate. And many times outside of the room, no one thinks this child is going to be a transplant candidate, but we can't say they're not a candidate. We just say not a candidate at this time. And that at this time tag is very, I think, hard to work around.
Yeah. Absolutely. Why? And you mentioned one reason why we add at this time. Why else do you think we speak in these terms? Why else do we say that not at this time?
I can only assume that the fear of giving, not being hopeful or taking away hope.
Yeah. Yeah, absolutely. Hard news is hard to deliver. There's some stuff that we'll talk about later on, but it really identifies that, oh gosh, I don't remember the statistic, but we'll get to it. But a huge percentage of difficult conversations had in palliative care include metaphors. And if you talk about something that might mean something different to you than to me, talk about, we're going to leave no stone unturned. They're stable. Things like that really are things that are not clear communication and can lead to really great misunderstandings. And as that oncology study clarified, that those misunderstandings lead to actual changes in the healthcare. And we may not have even known that happened, because to us, stable made perfect sense, or we told them they aren't a transplant candidate. That's great. Anything else? Any other experiences you guys want to share?
Becky, I was just going to comment that I think, again, that hope, it's such a delicate thing, but Jenny Mack has a great paper about parents wanting honest information, and that we don't take away the parents or the family's hope. So that was, for me, that was a very, good thing for me to remember and think about, and then how that informs delivery.
Yeah, thanks. Yeah, I think that's really true, that we really strive to give that hope, and we use words that are very qualitative in nature as we're doing that. And very much through our context. And that's the other piece of information and qualitative words, is that we filter them through our context, and they didn't speak it through our context. So we really can't accurately understand it through our context. So during this time, I kind of went through this list already, so we won't do it again, but we'll start with the very first one, which is identifying those qualitative versus quantitative words. And Dr. Dickey is always really quick to say, this makes sense in healthcare because we have a quantitative healthcare record. We have quantitative assessments. We have to work in quantitative. While we're listening to them tell us their story, we're thinking of our quantitative healthcare record over here in our episode charting, and where we're going to fit all these things in. We talked a little bit about shared context, and as humans, and certainly in palliative care, we share our stories in narrative fashion. Patients experience what is happening, what did happen, and relate that narratively. Qualitative words are then subjected to their context, to our context, which we might assume is shared, but it's really most often not, and then filtered also through the screen of perception, and then changed by the listener. Even something like, when I'm sad, I say, how are you feeling? Oh, I'm feeling sad. There's so many things that I think that means. And it's important to identify those words. I think saying a lumbar puncture was clean, that clean probably felt like a quantitative word, right? But it really wasn't. And so I think really learning to identify those qualitative words in what we say and in what we hear, and then ask for more context, that's really, really critical. Next is identifying and avoiding those high-risk words that have a high probability of leading to misunderstandings. Idioms and metaphors, this is where that statistic is. One study showed that almost 2/3 of physicians used metaphors in their conversations about serious illness. 2/3, that's a lot of metaphor. Can you guys think of, or do you want to share any idioms or metaphors that come to mind that we hear, that we use, that kind of get in the way?
Flying off the vent.
Yes, tell me more about that. Say that again and tell me a little bit more.
this has been particularly in patients that English is not their primary language. This is a huge thing. They don't, that term is often used to, as we're weaning and going to high flow and weaning down. And I had a parent who was not native to the United States. And she made this whole discussion about, what does this mean? This provider, and he was talking about one of our PICU providers, just kept talking about airplanes. It made no sense to me.
Yeah. And yet it's a really understandable perspective that they have. I feel like this is really, really applicable when we talk about cross-cultural care and those boundaries as well. Cross-cultural healthcare, you mentioned the English as a second language, idioms, they all really make very little sense when it comes down to it. And we're not even adding to it that at these times, there's a lot of endorphins, there's a lot of adrenaline, there's a lot of other things that make things seem maybe more intense than we realize, or we don't realize exactly how they're seeing it through. Any other ideas of metaphors or idioms that we use?
I had one in residency, and it was not with a seriously ill patient, but I was in the emergency room and we needed to do a septic workup on a baby. So we were preparing the mother that we were going to do a spinal tap, and my attending, wanting to reassure her, said, "We do this all the time. This is our bread and butter in pediatrics." And later, when I followed the patient on the floor, the mom was very upset because she felt like we were pushing it on them because we would get paid
Yes.
for doing that, and said, "She told me it's your bread and butter. Why? So why?" And this was an English speaking mother. There was no cultural divide. It was just something that we thought we were trying to make her feel better, and it had literally the opposite impact.
Yeah. And something that meant one thing to that speaker and meant something else to the receiver, right? I think that's great. Any others? Feel free to just speak up. So moving on just a little bit, professional jargon. We had a family where we shared the leave no stone unturned. They hadn't been able to get a diagnosis. It had been years. Some kids are really tough to diagnose, right? And so we used the term leave no stone unturned, and we didn't get invited back. And in talking with the mom about, that kind of transfer out, she said, "Well, you're just going to do everything. And we've already done everything. We're already exhausted. Right? We've already done all that. That wasn't what we were looking for." And again, that term, we meant it to be reassuring. We meant it to be comforting, and it just wasn't. Same cancer family, even with the word metastasis, because unfortunately this patient's cancer has now come back after declining to do the maintenance chemo. And what even the word metastasis means. If you can, I'd like you to think about the term a rare disorder, and what does that mean to you? Either write it down on a piece of paper. I'd have you throw it in the chat, but I'm not sure I can see it if you do, because my screen doesn't want to go off of full screen, and I'm worried it'll disconnect the whole thing. So what does, share with me, if you will, what a rare disorder, what do you think of when you hear that?
Unusual.
Unusual. Any other thoughts?
Something that you might not see a child with that diagnosis more than 3 to 5 times in your career.
Okay, great. Keep going. Anything else?
And because of that, we might
something.
Go ahead.
I think you're going the same place that I was going. Uncommon, and because of that, we might not know enough about it, or we don't know very much about it.
Yes, yes, exactly. Those are all true and really accurate. And what matters is what they think of when they hear that, right? And so even those kind of statements, can anybody think of qualitative things that we've gotten pretty good at making quantitative with professional jargon or verbiage? Anybody think of anything like that, that we think we're pretty good at making it understood by everybody the same?
So I would say, I put it in the chat earlier, I think it kind of fits into this. You know, when you ask someone in the ICU how a child, like a critically ill child's night went, they'll often say, oh, they had a good night, which in our professional jargon means, okay, they're stable. There haven't been any major changes, but you know, clearly to families, that means something very different. I was trying to look for there's a lovely article written about that. I was trying to look for the reference, but I still can't find it.
Yeah, that would be awesome if you do find it. I'd love that, but that's a great example. That's a great example. Any other thoughts? I think even the pain scale, I think even as we try to understand the pain scale and we think, oh, we've got that by picture, we've got that by number, we've got that so many ways, but do we take the time to say, I know what a 5 feels like to me, but what does that feel like to you? Or those sort of questions to get more and more from it. We're gonna jump to how to take reflective listening to the next level. And let's just use that last example. I know what a good night means to a NICU nurse, or a parent could say. From our training, we try to train parents to say, I know what a good night meant to me. I might not have had one last night, but you're saying my kid did. What does that mean to you? And then they might hear, oh, there were no changes, or there were no, other things that happened. Then they'll get some specifics. So working with patients and working with families and even residents and everybody else and ourselves to say, I know what this means to me. Can you tell me more about what that means to you? If I say to Janet, can you rate your pain for me out of 1 to 10 on a scale? Janet says maybe 2, right? Or whatever. And then I say something else, or suppose I'm reflectively listening back to her and say, oh, so out of like 10 being the worst and 1 being the best, you're at about a 2. Is that right? She's really only said 2 or 3 words through that whole time. And I think that's one of the red flags to listen for or to look for, is that when we're the ones doing most of the talking, there's probably likeliness for misunderstanding. But when we offer opportunities for them to give more information, to share more detail, more fact, to clarify, then that takes reflective listening to a whole different level, because they're the ones adding more information. It's not us parroting back to be sure that we understood them correctly. It's them saying more about what that means. The next thing is how to communicate more effectively in less time. A mom says, I hope my son gets better, but I know that's unlikely. I think here asking for more information on gets better, as we ask for that and say, oh, tell me more about what getting better would look like. Tell me more about what getting better would include. We already are having her map out our goals of care for us, because she's going to tell us what things he thinks he can improve back to. In situations like this, better can look like a lot of things. And I'm wondering what better looks like to you. I'm then really examining that and learning from her while I'm making those connections, while I'm having her know that what she has to say is important to me and I want to understand it. I'm also accomplishing some of those things that I have to put down in that healthcare record, or things that I need to do later. This type of communication does it really effectively. And it brings a lot more information out of the person rather than just agreement out of the person. Another statement that can come from this is, if it's unlikely that he will get better, what would you hope for in that case? And there we're learning a lot of other things about that mom, their son, and that statement. I think we've talked a bit about assessments and following up to get information. I did want to talk about some things to avoid, some red flags that we see that come up. We talked about when most of the words come from us as providers, that's a red flag. Connecting by sharing a similar experience. It's interesting because empathy is such an important thing in serious conversations. And it's nice to connect and to let them know of the empathy that we have. But it's so easy for that to turn quickly and become about us. And so it doesn't mean that we can't do it and that we can't connect and say, I experienced something similar and I know how that felt for me. I'm sorry or whatever, but it does mean that we need to be really careful that by attempting to make a connection, we don't go too far and turn it about us. And then assuming that we know what things mean. Some phrases to use to verify understanding and to clarify those qualitative things are, I know what that means to me, but tell me what blank means to you. Tell me more about your hope to have a successful transplant. I heard you say blank. I think we're understanding what you're saying, but it's important to me and I want to be sure. Those are some phrases that we can use to verify our understanding and to get more information. There's a meta-analysis done, and it didn't do what the cancer one did. It didn't talk about the bad things that happen when communication is broken and people are misunderstood and they don't trust. It went the other way. And it said that regardless of actual data and actual improvements, patients who trusted their providers felt more satisfied with treatment. They felt an increase in beneficial health behaviors. They felt fewer symptoms, and they felt like they had a higher quality of life. And I think if in any type of medical environment that's important, it's in pediatric palliative care, because how they feel is sometimes what we can offer. We might not be able to change things, but how we feel and how we can help them feel runs the day. And trust is just so important with those things. We kind of flew through some of this, but I hope that you guys feel like we've had a chance to talk about how miscommunication can happen, how that miscommunication really is serious and significant, and how we can improve in simple little ways, how we can improve that communication, and how we can empower others to do the same. So thank you for that. I think we're ending at about 2. Oh, here's that in the chat. I just can now see the chat stuff. It looks like there's some great information in there. So thank you for those. And there's a couple of them in there. Thank you. And I do know that they're recording these sessions. And so you can have access to this. If they share my slides, in there are the links to some of the studies that we've talked about. And then you can also enjoy the other sessions, like all the microaggressions that happen when miscommunication happens. That one sounded like a good one too. So thank you for coming. It's great to see you guys and to hear of your experiences, and cheers to better communication and things actually meaning what we think we're trying to say.
Thank you so much for this wonderful presentation, Becky. It was so interesting. I'm sorry that I hopped on a little bit late, since I was trying to make sure that everyone got to their rooms. Becky, are you available to just stay for like a few extra minutes in case anyone has any questions?
Yeah, absolutely.
If anyone, it is recorded. It might be kind of cut off for part of it, but we will eventually post it on our website for everyone to take a look at, and the other sessions will also be available. But if anyone has any questions for Becky,
yeah,
feel free to ask them.
we didn't really get to. Oh, sorry, go ahead.
No, I don't even know if this, and we're talking about communication, and one of the things that always, often when I hear families say it, I take a breath and try to figure out sort of how to proceed, is when a family tells me, we want everything done.
Yes.
And that everything can be, most likely we're already doing everything. I mean, most likely many times the child has already received all treatments that are possible. And then if there was something else, we'd actually be doing it. And so sometimes we want everything gets to be almost like an abyss of trying to get out of that, or having clarification, because often everything is being done. And they're, and just asking, again, like, let's try to figure out what are you hoping for? But it's sometimes can be really difficult in certain situations.
Yeah, and it absolutely can be difficult to try to piece out what are they looking for, because like you're saying, you're already doing everything you can think of, or you've brought it up. And so a question such as, and it's amazing to me how the most simple phrasing works great. Tell me more about what you're hoping for. Tell me more about what everything looks like to you. Tell me how doing everything helps things feel better. And in each of those answers, you'll get more and more and more information, and you'll really be able to piece together that they're looking for a way to be able to look back and say, I know we did everything, or they're knowing that they've heard crazy things on Facebook that you haven't done yet, and they're looking for when those are coming out, right? Like, you'll get that information from them as you continue to ask those questions. But I think that's so fantastic. I agree that those kind of statements are important to them, and important to empower them to dive deeper into what they're really saying.
Yeah, because I don't think there's anything in life that's everything. There's always a trade-off.
Yeah.
So it's always, there's nothing in life that's totally everything. Everything is a trade-off on some level.
Yeah. Yeah. And I do feel like it's okay to add their body is telling us that, and then add facts that is very clean, that is very quantitative, that they may not understand what those facts are saying. They're not producing any urine, and this is why. Those sort of things I think are okay to add at that time. Yeah. Matt, did you have something? Thank you, Gina.
Yes, thank you so much, Becky, for your presentation. My question, and I realize it might be different in different parts of the country in different settings, but does any part of your work look at, I guess, more of a long-term misunderstandings in communication that have to do with written communication that parents can see in the chart now? Things like that.
Yeah, what a great question. I think our work so far has not really done that. We've focused on the read, or the write, read, and reflect tool, and then empowering parents to know how to communicate better as a team member. But I think that what you're saying is really valid and really important, especially because they have access to so much that we maybe did not intend for them to see. Or will be taken out of context, or we're not there to, when they read it, to be able to interpret it or to put it in the right angle. And so I think all of that is really a new age in how we include what we include. I know for us, we offer to go through their patient portal with them. But we're a smaller practice, and we can do that, right? We sit in their living room, and we can help them find what they need to find and do that. But I think at the very least, it would be important to say, I know that when you're going through that, you'll have some questions and you'll wonder what we meant. And you might even find things that aren't right at all. Will you be sure to reach out to me when that happens? And just open the door for that communication and empower that teamwork. I think that's at the very least an easy thing that we can do. But I think that's a really great point, Matt. I wrote it down of something really to take a look at, the criticalness of all of that. I mean, you talk about acronym heaven is my charting, right? Because it's not designed for everybody else, but it is now for everybody else. Yeah, thank you.
Thank you.
Yeah. If there's not any other questions, I feel like I'd be not doing my job if I didn't mention the read, or the write, read, and reflect tool as a wellness technique for healthcare workers. It's a simple process where people take 3 minutes, a group of people, to just to write to a prompt. And like for our families, the prompt might be write a story about, or write of a time that caring for your medically complex child was either rewarding and inspiring or depleting and challenging. They write for 3 minutes. Everyone in the family writes, and then they read to each other. And when they're reading, they find these words, they find these connections, they have realizations about each other. And those are, you can clarify through those qualitative words, but also those connections that are made. And the write, read, reflect method was actually made for healthcare providers initially to, and then used really effectively to handle some of the stress of COVID and to flatten the curve for that. And so if anybody has any desire to learn more about that and how to use that in your practice or in your organization, I think reaching out to either myself or to Vivian, the executive director of the Narrative Initiative. I know with Lorraine's passing, things aren't exactly set of how things are going to go, but it's an incredible tool that you guys can learn how to use and has huge benefits and really great results of, hey, I can turn around and use this right away to improve my own wellness as a healthcare worker. And then we found it equally effective with families. And these things we talked about are part of using that tool and how that tool becomes effective, but the tool itself is simply that writing, that sharing, and the reflecting back process and the great connections that makes. Yeah. So great to be with all of you guys.
Thank you so much.